This is Vermont Edition. I'm Michaela Lafrac. Many communities in our region are home to a growing number of people who face multiple challenges at once: mental illness, substance use disorder, a criminal past, or homelessness. Police are often the first ones called in to handle incidents that involve a mixture of these problems, but they're not always in a position to offer ongoing support. Now, there are 1,000 different strategies that communities have tried, all with different buzzy names. This hour, we're going to hone in on two that are offering some level of hope right here in our region. Later in the hour, we'll hear about a program called contingency management that essentially pays people in small weekly amounts when they refrain from doing drugs. But first, we're going to talk about something that to me sounds a bit more like a military planning exercise than a social services strategy. It's called the Situation Table, and 8 communities in Vermont are currently trying it out. Our Vermont Edition team started looking into this program around last month when 7 Days reporter Courtney Lambden was a guest on our show. She talked to us about all the different ways that Burlington leaders were trying to address persistent issues with crime, open drug use, and homelessness. She told us about the hotspots intervention approach, where the police force places more officers in high crime areas, and she told us about situation tables.
It calls together a group of all sorts of stakeholders. So in Burlington, it would be the police. It would probably be some folks in the mental health services, and they convene kind of a discussion around. It can be any sort of problem. It could be someone like a mother who's trying to flee domestic violence. It could be something like that. But I think in Burlington, people are interested to see how this might work around folks who are kind of persistently causing problems. We've heard over and over that it's really a small amount of people that generate a large amount of police response in Burlington.
Senior public safety reporter Liam Elder Connors at Vermont Public has also been trying to learn more about this approach. He has a new story on vermontpublic.org out today, and he joins us now. Hey, Liam.
Hi, Michaela.
We also have Scott Allen with us, a retired police chief from Massachusetts. Now he works for Cordata, which trains law enforcement and social services organizations on this situation table model. Scott, welcome.
Good afternoon. Thanks for having me. Good to hear you again, Liam.
Yeah, so Scott was part of your story, Liam. And Scott, let's start with you since you're the expert here on situation tables. What are they? Who's at these tables?
Well, just to lay the context, how I got introduced to bringing the tables up to Vermont from Massachusetts was through the Governor Scott's 10-point safety plan. And the tables are designed to look at risk factors upstream. So when we look at risk, we think of different scales, and in different sectors, it looks different to law enforcement, fire, EMS, to hospitals, to behavioral providers, to persons with lived experience. So individually, we look at those through lenses and silos. What the table does, and what I found it to do for me as a police chief for my community and then my county, was it brought all the stakeholders together where we now have this shared lens to look upstream at those risk factors for individuals, families, and or locations that are what we call acutely at risk. If there's something is going to happen if there's not a collaborative outreach initiative to try to engage those individual families. And truly, that's what the table does, is it gets upstream. And I did want to just say that, the table has been working for almost 15 years now. It was created in Glasgow, Scotland. It came over to North America through our partners in Prince Albert, Saskatchewan, Canada. So just to kind of lay the framework for that. Hopefully that I did that efficiently enough.
You did. You did it justice. And Liam, can you tell us a little bit more about what you've learned about the history of this program?
Yeah, like Scott mentioned, we sort of saw it spread around Canada, starting in Saskatchewan and then over into the United States as well. And there are, I believe, 45 communities using the table model around the country in the United States now, including 8 in Vermont. And that's pretty recent. Those 8 have all been trained in the last year or so, and some actually even as recently as the last couple of weeks. Scott was up doing trainings in Barrie City, which is where we chatted for the story that I was working on.
And you spent some time, Liam, in Springfield. What's an example of how this situation table model might help an individual Springfield resident?
So one example that the police chief gave me was the table was addressing a situation where there was a single parent that had 5 children who were at risk of being evicted from their apartment. They had a voucher to pay for housing, but were having trouble finding a place to use that voucher. One of the agencies at the table was able to find a landlord who was willing to take that voucher, but the landlord's apartment that was available was uninhabitable and needed some renovations. And so the team that had convened to work on this issue realized that what they could do was rehab the apartment themselves and get volunteers together to do it, because there was a time crunch because the voucher was going to expire. So there were all these different factors and different groups that were coming together, and ended up the chief of the Springfield Police Department told me he was hanging sheetrock in this apartment to try to get it done in time, which he says is not exactly his specialty, but it was something that they were able to do to help lower the risk factors for this family. And Chief Jeff Burnham in Springfield says that it allowed them, he thinks, to get ahead of things, because if the family lost their housing, maybe they'd be having to live outside. We have such an acute housing shortage right now that a lot of people that lose housing don't end up in shelter. So giving people and helping people meet their basic needs for him is a way to get ahead of potential criminal activity or other issues that could burden law enforcement, fire services, EMS, and all those other social service agencies.
Yeah. It sounds like a pretty individualized and high touch model. Scott, I can see that being both a blessing and a curse for the scalability of something like this.
Well, it is a blessing because I like to say it's that magic at the table. It doesn't focus on just one issue. When we got introduced to Governor Scott, there was a challenge with violence in the state of Vermont. So the table was brought in to address that. But what the table does is it looks at all those other, sometimes related, sometimes not, risk factors that individually, not one agency or not one person can solve alone. But through the table, it builds that collaboration where you're working side by side with professionals that you're probably siloed off from in your day-to-day work. You might be able to pick up a phone and call an agency, but being at the table, everyone learns the different services, the different expertise they bring to the table. And then as at the table, we then look at those collective risk factors. So we're not just looking at one issue, because as we've all learned, many of these community health challenges, they're not just one issue alone. I always liken it to, think about the healthcare system, where if you have multiple healthcare issues, you've got to go to 5 different specialists. You've got to navigate that yourself. You're doomed to fail or be unsuccessful because you've got to try to get all the other doctors to talk one another. And that's this table. This table talks together and then collaboratively works to put this wraparound approach together to engage that individual family or location.
Well, if you're listening right now and you've participated in a situation table, or you have a friend or family member who've benefited from this type of support, give us a call. Tell us about it. 800-639-2211 is our number. You can also send an email with your thoughts or questions to vermontedition@vermontpublic.org. Now, listening to these descriptions of this model, in some ways it seems not entirely new, in that it's building on this idea of law enforcement and social service agencies coming together, working together, communicating, which I know lots of communities have been trying to do for years. First, Liam, and then Scott, I wonder if you could tell us a little bit more about what feels different to you about situation tables, having reported on public safety for years now.
Yeah, I think for me, I have seen models that are similar in my reporting in the past. I mean, there are 2 prime examples, Rutland's Project Vision, and in Burlington, former police chief Brandon Del Pozo brought CommStat to the city when he started in 2016, 2017. What struck me as different about the situation tables, there are kind of 2 main things. One, that we're seeing the state take an active role in getting communities on board and using this in multiple places. And it's the same model. It's not each community coming up with their own methodology for it. It's this sort of standardized approach, and the state is supporting it. And then, CommStat was really focused in Burlington on the opioid crisis. And obviously it could get into some other things, but it was mainly focused on addressing that issue, where this is more broad, I think, as well, and being used for many different issues that come up. And I think it's a very specific process. It is Scott can speak more maybe to the process, but the meetings run in a very efficient manner where the process is kind of the same every time, and it's meant to focus on specific people, places. It's sort of action oriented as opposed to broad generalized discussions, which I think is a little bit different than other approaches I've seen in my reporting.
Yeah, Scott, I'd love to hear more
Yeah.
about that as we try to
Yeah.
differentiate situation tables from other approaches.
Yeah, I think the first point that Liam made was perfect, head on. Is, the state, from the leadership level, the public safety enhancement team has been doing a lot of work in different spaces, data collection, looking at, violence in communities. What this structured process does for the situation table is it brings fidelity, because it has a model. That's we call it a four filter process. Anyone can, within the network, and it's not a community meeting, it's for providers, service providers, anyone that provides resources, to look at some of their case management, if you will, and say, who is slipping through the cracks that individually alone I just can't help this person without more assistance. And that four filter process is really, to me, the big difference. It's structured. We have a script. We follow a script. We're not tracking personal identifiable information. We're collecting only de-identified data. There's an opportunity to put a team together that then goes and works in a smaller group directly with an individual family if they're interested in those resources and help. We do that through assigned release of information. So that structure, we have tables in Corvallis, Oregon, whether you're in Corvallis, Oregon, or Burlington, Vermont, we're going to follow the same script each week. And there's a process. Anyone at the table can keep it. We operate through consensus. So there's no one entity that owns a table. I think that's what's different than this. It doesn't fall on one agency's shoulders, one person's shoulders. So the consensus of the group will determine if an individual family is at acute area risk. They will determine, through their shared experience and expertise, who the best resources should be put together for that one outreach engagement. And I'll finish with saying that, to Liam's point, we started our model in Plymouth County, Massachusetts, because of the opioid crisis, very similar way back when in 2015. But what we found was that, these collaborative models will work no matter what the issues are. And that's what the table does so efficiently. Is one day you can have a situation that is focused on substance use and mental health disorders, and then the next situation might be an elderly person that's a victim of violence, has other issues. So regardless of the age cohort, the table has all those agencies sitting there to say, hey, this is something that I can help on.
What about in a place, Liam, a small town, for example, where there might not be the agency that you're hoping there will be, or a specific social service that doesn't exist in Springfield but might exist in a larger place? Has that come up?
I haven't seen it yet, but I think one thing I have noticed is that there are some smaller police agencies in the Springfield region who are now joining the table. So I think what could happen in Vermont is that you see some smaller, more regionalized efforts where maybe it's not one community that is hosting the table, but perhaps a coalition or a more regionalized group, which I've started to see in the Upper Valley a little bit. I know the training down there involved Hartford, Woodstock, and New Hampshire as well. So that was more regionalized than just saying, okay, this is like the Burlington table or the Barrie table.
Right.
We could see some of that in the future potentially. I
Yeah,
would think.
Scott, what are your thoughts there as maybe
Yeah,
smaller
no,
towns
that
try
was
to grow these tables?
That was very strategic. And prior to us introducing tables as a tool, the public safety enhancement team had already identified, through their data collection and identifying at-risk populations, higher risk communities. So we worked with the public safety enhancement team to go into those individual communities to start. But then over the last year and a half, what we knew in advance was that the larger town cities would probably have a table that would host their neighboring towns. But in those smaller pockets, just like we did in Plymouth County, we have seven jurisdictions per table in Plymouth County. So there's seven jurisdictions with multiple agencies that will serve one table. So that's the beauty of the table, is that the Woodstock, Hartford, Norwich, hopefully surrounding towns like Bridgewater, those smaller towns will come to that table because they may not have the resources in their backyard, but through the table, they then learn about all the neighboring resources that can come over to their jurisdiction. Or oftentimes, an agency already serves them, but they just don't know it. That's what the table does. It opens up this communication. And again, that was very strategic, where as the tables have aligned in Vermont, under Commissioner Morrison's leadership, the idea would be to have these tables covering the various pockets across the state of Vermont, so that if you didn't have a table in your community, there was a table nearby that you could join. Like we've actually seen Springfield sharing situations with Brattleboro talking to St. Johnsbury. It's really opened up this communication network through a structured process, because every table operates the same way.
Sounds like there's real energy behind this approach. But let's talk funding. Liam, where's the funding for these trainings come from?
The state repurposed a federal grant to get this initial round of trainings going, and that money has now been used up. So when I talked to Department of Public Safety Commissioner Jennifer Morrison for the story, she said, expanding it further, would require more funding, and they're not exactly sure what that will look like yet, but that's something they're considering. So it's definitely something the state is looking into right now.
Yeah. We got an email from Will in Springfield, who says the situation table is a great way for multiple agencies to collaborate and connect people to what services exist. The problem, as I see it, working with the population who are in these crisis situations, is that the services needed are often unavailable, inadequate, or overwhelmed. The situation process needs to collect information about what needs to be added so that we can have a safety net. Right now, we don't. We have an ocean of hardship and a few islands of support. Scott, I'd love your thoughts on that email.
So that's another beautiful part of the situation table, is we're tracking de-identified information to identify what's working, but more importantly, where the gaps are. So I'm looking right now at what the top risk factors across Vermont's combined tables are. Housing is number one, substance use by person is number two, person being unable to meet their own basics 3 is number 3, alcohol use 4, person living less than financial situations 5, general health issues 6. So what we can do with that de-identified data is look at it collectively across the state to then say, to Will's point, which is a great point, hey, this is a gap. But we have these communities that are working together. They continue to see this gap. How can we then collaboratively put funding together, possibly put together a proposal? It opens up a lot of other opportunities with that data. Because that's what we did in my community way back in 2015, 16, was we used the data. We built a table. We built it with nothing other than just getting some original training, and then all the other resource providers came to the table to say, hey, we can contribute in kind to this team. So we built kind of that, if you build it, they will come. That's what the table can do to fill those gaps. But Will is spot on. We're not gonna solve all the problems. It's one tool on the Vermont PSET, continuum of care, but that tool can then help leverage the data to show where the resources need to be allocated, both locally, state, and then federally as well.
And then as we look to the future, Liam, is it up to the community leaders to keep these situation tables going? Do they run on a timeline? What comes next?
I mean, that's my understanding is, the state has helped with the training, and then it's up to the communities to kind of take it from there. The Springfield has been really happy with how the table is run. Burlington just got theirs up and running in the last couple of months and is sort of starting to use that process more. But I think to what Scott and what Will were writing in about is that there's the table, to my mind, seems to be really good at focusing on specific incidents and acute and short-term issues. But there are a lot of broader systemic issues that are going to need to be addressed as well. And this might help hone some of the state's approaches, but I think there's still a lot of larger discussions on how do you tackle these The housing crisis obviously is huge in Vermont, and there's a lot of different things that need to be done to address that, in addition to what is being done with the situation tables.
You can read Liam Elder Connor's story about situation tables on vermontpublic.org. Liam, thanks as always for joining us.
You bet.
We're also joined today by Scott Allen, who works in community engagement for Core Data, a healthcare organization who has been leading trainings on situation tables. Scott, thank you so much.
Well, thank you very much for having us. And I like to say Vermont has now become my second home. I love actually of it up in the Green Mountains, coming from the White Mountain State, going to college. But thank you for having us up in Vermont. We really appreciate Vermont. That you are our friends and neighbors, and we're looking forward to continuing the collaboration.
Oh, well, we're glad to hear you call it home as well. All right, we had to take a quick break, but coming up, we are going to hear from a member of Burlington's situation table. We'll also hear about another intervention program being tried out in Vermont that pays people to stay away from drugs. It's a little more complicated than that, but we will share more in just a moment. Stay with us. Welcome back to Vermont Edition. I'm Michaela Lafrac. This hour, we are discussing different approaches to helping people recover from opioid use disorder and stay out of the criminal justice system. This next strategy can be a controversial one. It's called contingency management, and it incorporates a reward system into treatment. Here to tell us more is Jess Kirby with the Burlington-based organization Vermonters for Criminal Justice Reform. They operate a recovery center and offer support services for people with substance use disorders who have been involved in the criminal justice system. Jess, welcome.
Hi, thank you for having me.
We're also joined by Tyler Erath. He is an assistant professor of psychiatry at the University of Vermont. He also co-authored a key study on contingency management. Tyler, welcome.
Thanks for having me on the call.
And listeners, if you are familiar with contingency management or have thoughts on this approach or questions, you can give us a call at 800-639-2211 or email vermontedition@vermontpublic.org. Well, before we get to contingency management, Jess, I would love to hear about your experience as part of Burlington's relatively new situation table, which we were just talking about at the beginning of this hour. What has that experience been like for you so far?
Yeah, so we're really excited about participating in it. So far, it's been really great. It's really, a tool to help the community. A lot of providers who have a lot of people who are really struggling, be able to come together in one place once a week, talk about some of the people who are struggling the most, some of our most vulnerable community members, and identify, who are the right programs, who are the right people to work with this person, how can we work together collaboratively to try and help this person meet their need, reduce their risk, and reduce their impact on the community.
Yeah, so it is really, really individualized.
It is.
Yeah?
Yeah.
Do you think that's a key element of its potential success, that you're talking about like an exact person rather than like a group of people?
Right. I do think that is an important aspect. And, we do that with, of course, permission from the individual.
Sure.
A lot of people are really also, the people that we're working with are feeling really defeated, and they're willing to try different things, and like, yes, sure, help me with the team of people, help me move forward, help me get housing, help me take a step in the right direction here. So I do think that's a really important aspect, to make sure that people are really out there trying to engage with people who are really, really needing the help.
Yeah. And Tyler, as a psychiatry professional, you've been listening to this conversation about situation tables. I'm curious if you're familiar with this approach, and even if you haven't been before today, what your thoughts are, your initial thoughts are on it.
Yeah, that's a good question. I was actually just talking with Jess a little bit earlier this morning, and I hadn't actually been aware of it yet. So I'm looking forward to learning more about it as the program develops, and maybe try and get involved, if possible, with the one here in Vermont or in Burlington.
Well, let's turn to this other strategy we'll be discussing today, contingency management. It sounds very corporate. Tyler, what exactly does that mean?
Yeah, it is a term, right? So contingency management is a treatment that helps individuals reduce or stop their substance use. And the way it's doing so is helping by providing positive rewards for healthy behaviors. And so I think, one of the ways we can think about it is the approach itself is pretty straightforward. So when someone meets a treatment goal, and this could be, for example, if they provide a stimulant negative urine drug test or they attend a counseling session, then they'd be earning a reward. And so those rewards are typically in the form of gift cards or vouchers that could be exchanged for everyday items. And so the treatment itself is actually based on the science of behavior change. And so from the research side, one of the things we know is that individuals are more likely to repeat a behavior that they've been rewarded for. And so in contingency management, what we have is a reward system where it's reinforcing progress in their recovery. So, for example, each time someone provides a stimulant negative urine drug test, then they would earn that reward. And so, in general, contingency management as a treatment is especially effective for stimulant use disorders and for other drug use disorders as well. It's just that with stimulant use disorder, there's currently no FDA approved medications, and it's by far the most effective treatment that we have to date for the treatment of stimulant use.
Okay, so when you're talking stimulant use disorders, you're talking about a certain class of drugs, cocaine, for example, that might
Yep.
be different than some of the drugs that are often used in communities in Vermont that we're seeing right now, opioids, fentanyl, the like.
Yeah, I mean, I would say that there's historically a lot of stimulant use in Vermont as well. And so one of the pieces that we see often today, and so one of the ways it's conceptualized is we talk about the opioid or the fentanyl crisis. And what we've been seeing, there was a paper recently that called it the silent epidemic, but it's the co-occurrence of stimulant use alongside fentanyl and opioid use over the last handful, 10 so years. And just if you think about with our data here in Vermont in particular, um, it's not widely as known, but 7 out of every 10 fatal overdoses that occur also involve stimulants, primarily cocaine. And so it's a big driver and one of those pieces that we've been working to help sort of shine some light on and bring perspective to with what supports and services can be done to help address this other part of the overdose epidemic.
Now, Jess, you run Incentives for Success, which is a contingency management program. How does it work in Burlington?
So, Incentives for Success is a program that utilizes contingency management. It's actually right now we're doing it. We've had different cohorts where we've utilized contingency management, but this one is in a partnership with Sarah George's office, the Chittenden County State's Attorney, and we received some funding from the Vera Institute of Justice and the UVM Medical Center, and it's about bringing people with nonviolent misdemeanors, usually a lot of them with, having obviously a really high impact on the community, that have really high needs, and also really struggling with substance use disorder that's typically untreated. And it's about diverting people from the criminal justice system that, are really in need of services, really in need of treatment for their substance use disorder, and are really likely to keep reoffending if they don't have their needs met and they aren't brought into services. And this is a really effective engagement tool and a really effective way of helping people treat their substance use. And just as importantly, helping people get connected to things like housing, things like medical care. Sometimes people haven't had medical care in 20 years. It's really hard to take steps forward if you have so many untreated needs. So we really kind of came up with this idea as an innovative diversion tool to try to help people who keep bumping up against the criminal justice system and really not having any support and any forward movement, people that are really typically not engaged in services, really challenging to reach, really challenging to engage. We have this awesome engagement tool. People, want to address their criminal justice issues. We have a lot of built-in trust and buy-in with the population, and that's been really helpful. And it's about trying to help people get their needs met. Yeah. So, and finally get some treatment for their substance use and help with stability.
Yeah. So when somebody in Burlington gets oriented into this program, they start coming in for a weekly check-in.
Yep.
What happens at one of those check-ins?
So people, it's a minimum of a weekly check-in. Most people come 2 or 3 times a week. Sometimes we see people every day. But what's required is a weekly session that utilizes contingency management where people would come. At that first session, we're really identifying needs, identifying problematic substance use. Another component of the program is that people have to want to work on their substance use. They have to be in a place where they're trying, they want to take steps forward with their substance use and reducing their substance use. And so we would identify needs at that first session, and then at sessions following, every week when they would come, we would do a UA that would test for a UA is a urine drug screen, where we would test for the substance. It's typically stimulants, but we are utilizing like a choice model where people can choose what substance they're getting the contingency management incentives for. So sometimes that's fentanyl, sometimes that's stimulants. And so people will come, they'll do a urine drug test, they'll have, brief counseling on their experiences that week, answer a set of questions. We'll see what their drug screen results are and talk about that. We talk a lot about harm reduction and reducing risk and reducing overdose risk. And we do case management with them. We work on getting on the list for coordinated entry, which is Chittenden County's sort of, system for trying to house people that are chronically homeless. And it's really hard to get housed if you're not at least on that list. So we're helping people make sure they're there, helping get IDs, birth certificates, social security cards, helping people get into MOUD, medications for opioid use disorder. So we're helping a lot of people get methadone, taking them to their first day at the clinic, helping a lot of people access inpatient treatment.
So you're helping them with so many different services, introducing them or kind of helping them access some of these services. And then at the end of this meeting, they receive a gift card. Is that what it is? For how much?
We use something called a PEX card, and it's a reloadable Visa card. People get a participation incentive for coming. It's a really small amount of money. Week one is $12. They get $12 on this prepaid Visa card for participating in all of these services. And then they would receive a bonus incentive that's that same amount. So like $12 on week one for participation, and then they would get $12 for a negative urine screen. So they could potentially get 24 that week if their urine drug screen was negative. And then the following week, it goes up by $1 each week. So week two would be $13 for participation, and then a $13 bonus incentive.
Okay.
So.
I want to hear more from you, Tyler, about why these types of incentives, though they might sound relatively small to some listeners, why they do indeed work to help people come back week after week to access some of these types of services. We do have to take a short break, though, so I'll let you chew on your answer, and we will be back with more Vermont Edition in just a moment. Welcome back to Vermont Edition. I'm Michaela Lafrac. This hour, we are discussing intervention methods that communities can use to address overlapping issues like drug use and crime. Right now, we're learning about contingency management, which essentially offers people small rewards like gift cards for not using drugs. Our guest is Jess Kirby from Vermonters for Criminal Justice Reform. She helps lead their program Incentives for Success, which uses contingency management. We're also joined by Tyler Erath, an assistant professor in the UVM Department of Psychiatry, who co-authored a study on contingency management. Tyler, could you tell us a little bit more from this psychiatric perspective about why small rewards, could be even $12 a week on a prepaid gift card, can do so much to get somebody through the door and accessing important social services?
Yeah, it's a great question, and it comes up of how are these rewards actually operating? And so what we know, at least from the behavioral side, is that these rewards are operating as an alternative sort of potential source of reinforcement that someone can earn. So if you're thinking about as it relates to drug use, the way Jess had described the program and the way that contingency management works is that it's very protocolized. There's a known sort of structure of how much someone can earn and for what. And so what it does is sets that structure up so that where those incentives, if someone comes into a situation where there's a potential opportunity to use, but then they know that 2 days from now I have my results or my CM visit, well, I may not use that day because I've already going to earn 12, 20, whatever the incentive amount might be. And I can, they're thinking about that incentive and what it can do, what it could be used for. And so really at the sort of central component of what contingency management's doing is restructuring the opportunity for where reinforcement or incentives can be earned. So taking that immediate reinforcement that someone may receive from using in that particular instance and shaping it to where instead of doing that, there's this opportunity to earn this reward in this other way, which is what we're talking about with the incentives.
If you have questions or thoughts about contingency management or this reward system that some communities are using to help people struggling with drug addiction, you can call in at 800-639-2211 or email Vermont Edition at vermontpublic.org. Jess, who funds this program? You mentioned that there was money from opioid settlement funds that Vermont receives. Was that the situation tables?
I don't think opioid settlement funds are they're definitely not used for our contingency management program.
Tell us how yours is
Right,
funded.
okay.
How is it Incentives for Success funded?
That's through the Vera Institute of Justice.
Okay.
And they fund innovative diversion programs trying to divert people from incarceration and away from the criminal justice system and into services in hopes of having better outcomes. And also UVMMC funds the incentives and the drug checking materials like the urine drug screens and that sort of thing.
Tyler, I wonder about communities receiving funding for contingency management programs. Has that been a struggle in the past to maybe convince the broader public that this is a effective use of funds?
Yeah, it's been a very recent phenomenon, actually, of getting contingency management implemented on a larger scale, so say at like a statewide program.
Yeah.
So what's really interesting is that contingency management as a treatment, particularly as it relates to stimulant use, actually is a homegrown Vermont intervention. So Dr. Steve Higgins at the University of Vermont conducted the first study on contingency management back in 1991. And it took until about 2020 before we actually started seeing any sort of efforts at a larger statewide scale to be implemented. And part of it was funding, or the most critical piece both then and now is funding. So where do the incentives come from? And that's where Vermont, I've had the great opportunity to work with Dr. Rick Rawson and myself, work with Department of Substance Use, providing the training and technical assistance on the contingency management rollout here, where there's about 15 to 20 providers that are participating so far. Vermont was really innovative in the way that it funded contingency management. So it's actually funded through opioid settlement funds, as you noted. And that's been the case for the last couple of years. And what's really, it's innovative in the sense of both using opioid settlement funds to do so, and Vermont was actually the first state to actually go out there and do that. So it's been a great learning experience on how to scale it up and what that looks like, and offering other states that are potentially interested. One of the things we're continuing to learn is just as this is being implemented, steps along the way, lessons learned, and how other states could benefit if that becomes of interest to them as well.
Yeah, Jess, is that something that that you have thought about, like talking to other communities or folks in other states about how to replicate the program you've been a part of here?
Yeah, actually, we've had a lot of interest from other parts of the state and have helped some Howard Center programs and other programs around the state, just kind of talking to them about what our experience has been, giving them tips about, what cards we use for the incentives. Also, there's been some interest in other parts of the country. Actually, some prosecutors, state's attorneys in Virginia actually came here and visited our program and the Chittenden County State's Attorney's Office in hopes of learning more specifically about this diversion with contingency management protocol and wanting to replicate it. And they actually are replicating it in Virginia, which is really exciting. There's been other parts of the country where they are wanting to use contingency management specifically with, people who are experiencing homelessness and trying to help them use contingency management to, stabilize and retain housing. And so there's actually a lot of interest right now with contingency management, which is really exciting. And we're really happy to, try to lend our expertise and what we've learned so far with starting a program like this. It's been really fun.
And where does your program stand in sort of its like broader timeline? Because it's been going on for a little while now.
One thing I should also say is when people are diverted into this program, one thing that's really important to note is that if people don't participate, if they get diverted and they don't have to go to court anymore and they have these pending charges, really what happens is they're just being made inactive for a short period of time while they have an opportunity to engage with us and engage in services and show that they are going to engage and move forward with treatment, etc. So if they don't engage, then their charges will become reactivated and it'll be right back on the court docket as if this never happened. So it's not really a huge risk to the, court system. It's giving people an opportunity to participate, and if they don't, then they'll be back in court just like as if they had never.
Okay, so it's like the charges are wiped for good.
Right. They are dismissed if the person successfully completes. So and
as for the timeline,
the timeline. So we had agreed. We had a grant to take 50 people, and so far we've taken between 30 and 35 people have participated, and we will definitely continue and take the full 50, but it definitely depends on funding. We aren't accessing the opioid settlement funding for that, so we have to just make sure that we could continue to fund it, but we know that it's really effective. It is so effective at bringing people that are really challenging to reach into services, and over 90% of the people that have come into the program are still engaged with us even after completing. So that shows that it's effective at bringing people into services long term, and then it's giving us an opportunity to retain people in services and make sure that people have support through all the bumps. I'm a person in recovery myself, and I know that it's really important, in those, especially in those early years, that people sometimes go to treatment and they come out and they have hiccups, they have bumps, they lose their medication, their buprenorphine, they have, a family crisis, they have a personal crisis, they lose their housing, they lose their job, they, struggle with cravings, substance use is chronic and relapsing, and it's really important for people to have support long term. And so it's a really big success that we're keeping people retained in services, and this is a really great way to bring people in. But so we don't know exactly how long we'll be doing it. It's definitely funding dependent, but right now we are still enrolling and really excited about continuing.
Yeah. That's exciting. And thank you for sharing that part of your story with us as well.
No
we just got an email from a listener named Britt who had a question about the success rate for these programs, which we were just talking about with you, Jess. And Tyler, I'm curious for your thoughts there too on how we measure success with an approach like contingency management, because with so many different programs that address opioid use disorder, it can be hard for everyone to agree on like what success means. Is it, reducing the number of opioid related deaths in a community? Is it, getting one person into a recovery facility? What does it mean to you?
Yeah, it means all of those things, and I think it depends on what level of granularity or how we're looking at it from even down from the individual level up to the population health level. Jess's point on the retention and engagement in treatments, one of those really important ones too that we're also looking at here in the statewide efforts in Vermont, of how are people staying engaged? Because just having contact points and touch points with someone a couple times a week, as Jess noted, can be helpful for, accessing other resources, check-ins for health-related reasons or whatever that might be. And so I think when we're talking about outcomes, what we do know about contingency management, at least from the research literature side, is that it's by and large, when we're talking about for stimulant use disorder, the most effective treatment. So numerous meta-analyses, big studies that have combined across hundreds of studies, pull them all together, and it shows that contingency management is the most effective intervention that we have available. So we really know on the individual level about the efficacy, and what we're starting to see as the program rolls out, and a few other states are also rolling out programs as well. Now we're starting to get some more data on the public health side that we hope to be able to speak to in the future on How does this not only reduce drug use, but also help with treatment engagement more generally? What do those outcomes look like longer term? Which there is data to show that participating in a treatment contingency management now leads to better outcomes even at a year follow-up. So I think what's going to be really fascinating to see over the next few years is being able to follow those outcomes in more of a public health sort of way. Once the state rollout, you can start seeing sort of those ripple effects as they come in.
Yeah. Jess, I don't want to ask you to share any personal stories of somebody who hasn't consented to that for this program, but I am wondering if there is a person or a story, an interaction that comes to mind when you think about your time with this Incentives for Success program, of interacting with somebody and saying, "Hey, I think this really might be working for
Definitely.
them."
I'll give you two really quick ones.
Yeah.
One is my own. I actually was so excited to do contingency management because I actually participated in a contingency management program for stimulants myself. A long time ago, back before we had any programs that were doing this. It was at the UVM. It was a study. I participated in it and had been having a lot of trouble reducing, I wanted to stop my cocaine use, and I was having a really hard time with that. And I participated in a contingency management program, and it worked so well for me. I loved the people who were, doing the program. I loved meeting with them. They were helping me with various things. I was choosing to add up my incentives to have a bigger amount. I was like making car payments with it and getting new clothes that I really needed. And it was actually more about how proud I felt of myself and how they celebrated with me.
Yeah.
When I, had another negative UA, it just felt so good. And it felt like I was earning something and working hard. And I had a group of people that were celebrating with me. And it worked really well for me. I think by week 3, I had stopped using stimulants. And, I had a few bumps in the road, but I was, very successful overall. And that was one of the reasons I wanted to do this, because I had such a great experience, and I really wanted to help other people. And in terms of right now, I think of one person who is a new parent who had a couple, nonviolent misdemeanor charges, and he was referred to the program. He did really well. Contingency management worked really well for him. We helped him access inpatient treatment and reduce barriers to getting to, the methadone clinic, gave him a touch point, of people that were in his corner caring about him and helping him work through, each bump as it came up. And, he did really well. He, did some media about it and talked about, how impactful it had been for him and how good it felt, and how it felt really good to be able to have a little help with some of these basic need things, having stuff for hygiene products, having a little bit of money for gas, having a lot of people save money for Christmas presents. A lot of people are buying pet food or, stuff for their kids. People really feel good about saving it up. People get a $100 bonus incentive on the last week when they complete. And, we just make it a really big celebration. Hey, you completed this program. You did great. You came. We're working on all these important things now. Look at all the growth and progress you've made. And this person that I'm talking about, he just felt like it was a really big game changer for him. And he's had some bumps in the road, but overall, he's housed now. He's working, he's parenting, and doing really wonderfully. And it's just been really awesome to be a part of.
Oh, that puts a smile on my face. Good. Thank you so much for sharing both of those stories with us and for telling us about your work. Jess Kirby is with Vermonters for Criminal Justice Reform, and she helps lead their program Incentives for Success. Jess, thank you.
Thank you.
We're also joined by Tyler Erath, an assistant professor in the UVM Department of Psychiatry, who's authored a study on contingency management. Tyler, thanks for sharing your expertise.
Yeah, thanks for having me on the call. I appreciate it.
All right, that is all the time that we have for today. As always, you can weigh in on our show. Tell us what you thought of this conversation or pitch us your own ideas by emailing Vermont Edition at vermontpublic.org. Today's show is directed by Mary Angish. John Ahrens is our managing producer. Andrea Lorian and Daniela Fierro are our producers. Our call screener was Kelly Delorier, and our theme music is by Myra Flynn. I'm Michaela Lafrac. Thank you so much for listening, and we'll catch up again soon.